I think another question I have, and then maybe I will have either Dr. Sen or Dr. Marks answer. So, Dr. Yoon, you mentioned percent of tumor fraction when you look at the cell-free DNA. And you mentioned that really at this point, we really don't make a decision if it's like 7% or 14%. We do make a decision if it's a 50% because that means something to us. And I'll have maybe Dr. Sen and Dr. Marks explain what that means. But, is there a minimum number that we need in ctDNA or liquid biopsy to believe that a mutation is truly there?
Yeah, I don't think that there's like a hard set percentage that we necessarily need. But I think the higher the number, then, then it tells us that there's more of the tumor DNA in the blood. And so based on that report, then we're seeing more of the tumor DNA information. And I think that, if we don't see something in the blood and the tumor fraction is low, right? Like, are we really convinced that there's enough tumor DNA there to say that it's negative? So I think that's where it can, that tumor fraction is kind of informative for oncologists.
And can somebody take the question of what does that mean if your variant allele fraction is like 49%, 50%? What does that mean for the patient and what do we need to do?
Do you want to take this, Dr. Sen?
Sure, I can talk about, what does that mean? So tumor fraction, we mean the percentage of circulating tumor DNA in that blood sample. So it is a biomarker, as my colleagues have mentioned. So it's really analyzing the amount of ctDNA, and it's a ratio of the circulating tumor DNA to the cell-free DNA that we find. And it can depend upon a lot of factors, which could be anything between, the allele frequency, fragment length, aneuploidy. So it's a lot of things that is taken into consideration into making these decisions. But in a broader term, it's really the percentage of circulating tumor DNA that's what we call as a tumor fraction. I don't know if that answers the question.
Yeah, I guess the last part is if it's above 50%, I think that would validate or warrant more testing. Specifically, that would be very suggestive of a hereditary or genetic alteration. So that requires a whole nother set of testing on a different platform, but especially to inform genetic counseling decisions. I think in that case that would be important to go in that direction and make sure you get those additional tests.
And Dr. Bazhenova, your previous
Go ahead, Dr. Sen.
Yeah, your previous question about liquid biopsy versus tissue. I would also like to mention, the disease matters. In small cell, when you do tissue-based, you look at mutations, right? Which is not, right now, we don't have targetable alterations in small cell lung cancer. And I think liquid biopsy in that area can really help us in understanding the progression of the disease and seeing when the disease recurrence. So I think for small cell liquid biopsy, and since the tumor sheds so much CTC into the blood, the circulating tumor cells into the blood, I think liquid biopsy and the disease a lot more. And I think in that case, not just the DNA information, I think we have to go a little deeper into the RNA and the protein information. And that's where we are going next, right? So going to the next level based on the disease that you have. How can we tailor it to the disease?
Yeah, and I think what Dr. Mark said, I completely agree. So if you look at your liquid report, the liquid biopsy, and you see the VAF next to like 45, 46, 50, 52, definitely talk to your oncologist because that means that you might have a germline DNA abnormalities. These, which will not really affect what we do for you, but it might affect a desire of your first-degree family members to be tested as well, right? So we see Lynch syndrome. There are some inherited EGFR mutations that they're very rare, but we see it once in a while.